will have a quick recap on what we discussed last week. We tried to analyze whether labor analgesia was actually necessary. And we finally found out that it was absolutely necessary. And we discussed on the different techniques that were available, the pharmacologic and the non-pharmacological techniques that were available. And finally, at one level, we thought that let us not go into the depths of the rest of the techniques and stop short at the neuraxial techniques only. And the three neuraxial techniques which I mentioned were the combined spinal epidural, the single short spinal, and the continuous lumbar epidural. Finally, when we decided on the three techniques, we discussed on how to choose between the three, which one where. And then, supposing we had decided on one technique and when to institute epidural, whether to start it very early in labor or late in labor, or whether at the time of the mother requests it. And then when you decide on epidural, where to place the epidural, which interspace, we found out the ideal place. Now, when we decided on the interspace where we have to do the epidural, we wanted to see the techniques of identification of the epidural space, and finally zeroed on the loss of resistance technique as the ideal one for locating the epidural space in pregnancy especially. And then discussed between the loss of resistance to saline and air. And that's where probably we stopped last time. So now we have decided on the epidurals, located, the catheter inserted, and what next? How to go about further. The next thing that comes to our mind is test dose. So whenever we place an epidural catheter, for whatever reason it is, maybe for surgical anesthesia, maybe for post-operative analgesia, whatever the reason is, when we place an epidural catheter, we give a test dose first. Now, the idea of test dose is to see whether my epidural catheter is lying in the place where I want it. And that's the thing. Now, let us go discuss about the test dose a little later, because some knowledge about the drugs is necessary before we go on to what test dose should be given. So let's see the drugs used in epidural first. So the drugs used in epidurals, the local anesthetics, we all know all local anesthetics have been used, starting from the one which was, which has been used for a long time. The first spinal which was given, from that time onwards, every local anesthetic has been used for labor analgesia. But the time-tested one, the one which has stood the test of time, is bupivacaine, and closely followed by ropivacaine and levobupivacaine in the past 2 to 3 decades. But if you see the concentration difference, the bupivacaine is probably the most, the efficacy of the blockade. If you consider the quality of the blockade, probably bupivacaine scores over the others. Why others have become popular is because of the cardiac toxicity, for which bupivacaine has the highest toxicity. Does not mean that ropivacaine and levobupivacaine do not have cardiac toxicity. They also do have, but the level at which, the plasma concentration at which bupivacaine develops cardiac toxicity to the other two are different. They are a little resistant. The second group of drugs which are used are the opioids. Whether to call opioids as adjuvants or not, I'm not very sure. Because on occasions, opioids act as adjuvants to the local anesthetics. But primarily, fentanyl and sufentanil, and sometimes morphine, can act independently also. So I have grouped them separately from the adjuvants. So the ones which have stood the test of time are fentanyl and sufentanil. Sufentanil was for a short period of time, was available in India. I have used it in India itself. And within a short period of time, maybe a year or two, it went out of market. I don't know why it went out of market, but it is not available now. It's only fentanyl. So today, I don't have a labor epidural without fentanyl. Most of the times, I use fentanyl definitely with a local anesthetic or without it. The third group of drugs are adjuvants. About the adjuvants, we do not have definite scientific evidence to say that they are very, very useful. So before that, let's see what is an adjuvant for. An adjuvant in neuraxial anesthesia is supposed to enhance the action of the primary drug. Primary drug, if you think that is a local anesthetic, the adjuvant should enhance the action of the primary drug and reduce its requirement. The primary drug requirement should come down with the use of the adjuvant. And the quality of the block and the duration of the block should get excellent, should get enhanced. And that is what an adjuvant should do. Frills in the skirts, should supplement the beauty of the skirt. Local anesthetics are like the skirt and adjuvants are like the frills. It glorifies, it beautifies the skirt. They should glorify the beauty of the skirt. But what has happened nowadays is that the frills have become so many and so knotted that the skirt has disappeared. The frills only remain. And this is one of the reasons why I'm not very sure, without scientific evidence, not to advocate it as a primary drug. But there is a lot of scope for research that exists especially about dexmedetomidine and to a certain extent clonidine also, wherein probably in a few years down the line, we can include the alpha-2 agonists as one of the primary drugs itself. I don't know. But I will not declare them. I will not discuss much about it because you don't have definite evidence about it. We all know that labor pains have two components, a somatic component and a visceral component. Somatic component is basically blocked by the local anesthetics only, and visceral component is blocked by opioids and to a very great extent by local anesthetics also in a little higher concentration. So the best thing is to use a combination of a local anesthetic and an opioid for the best possible results for labor analgesia. So drugs used in labor epidurals, we have some standard customized mix. Now these terminologies, LDM, ULE and MEN, which I am talking about, do not appear in any of the textbooks. They are the nomenclature which we have made for our own purpose. And LDM and ULE, the low dose mixtures, and ULE is ultralight epidurals, are the two terminologies which my guru I accepted last time, Dr. Sunil Pandya, has coined these terms. And the rest of the terms are my own. And they are the mixtures which I use. And the names are only for my institution. If you people want to copy it, I have no objection. A low dose mixture means, so if you see low dose LDM and ULE, the low dose mixtures and the ultralight epidurals, I will, from now on, I call them as LDM and ULE only. Both of them are bupivacaine mixtures. So you can see them, bupivacaine mixtures. The difference is in the concentration. Low dose mixture is slightly a higher concentration compared to the ultralight epidurals. Bupivacaine 0.1%, and both of them contain fentanyl 2 mg per cc. And bupivacaine 0.1 per cc is LDM, and bupivacaine 0.0625%, which is slightly less concentration, is ULE. MEN is what I coined this term. MEN is mixture epidurals new. That is because leobupivacaine came later on, and I started using them. I called it as MEN. Leobupivacaine 0.1% with fentanyl 2 mg per cc. This was with the leobupivacaine. Then came rupivacaine. Rupivacaine REN1 and REN2. Rupivacaine epidural new. So REN1 is rupivacaine 0.1%. REN2 is rupivacaine 0.2%. These are the 5 mixtures which I am using. And these are the only 5 mixtures which we talk about. And the entire talk, I will be dealing with the bupivacaine mixtures concentration only. And it can be extrapolated to the other 2 drugs as well. So bupivacaine, now I gave you 2 concentrations of bupivacaine, ULE and LDM, low concentration and a slightly higher concentration. Which one to use? Depends on the anticipated intensity of pains. Supposing it's a primi para. Primies will have a higher intensity of pain, as all of you know, compared to multipara. So in primi, probably I would prefer an LDM compared to ULE. An occipito-posterior position. Because of the position itself, the pain intensity is higher. A transverse position. An android pelvis. The pelvis does not allow the fetus to progress. And these are the situations where the pain is higher. The intensity of pain is anticipated to be higher. We use the low dose mixtures, and otherwise it is ULE. Now, we have decided on what to use, whether it is LDM or ULE. Whichever concentration we are using, any one of them, whichever is the mix that we are planning to use, 10 to 15 ml in the fractionated doses, that is 5 ml aliquots, 5 ml, 5 ml, 5 ml aliquots is the first dose of the epidurals. That's how we decide. Now, after about, we give 5 ml, anything less than 10 ml will not be adequate. So we use 5 ml, wait for about 2-3 minutes, give another 5 ml. And if everything is fine, within 10 mls, in about 10 minutes time, the level of the block is tested. And most of the times, the visual analog pain scores will be less than 2 of 10 in most of the situations. If it does not happen, we give another 5 ml. So in about 10 minutes time, we give about 10 or 15 ml and get the visual analog pain score to less than 2. This is the first dose. The VAP score should be near 0, or at least the worst we can think of should be less than 2. If it is less than 2, we usually accept it. And the patient who is like this should start smiling, should start pointing towards the visual analog pain score towards 0. And this is what we actually anticipate it to be. We expect it to be. Okay. Now, having said all this, let's come back to the test dose. And I wanted to tell you about the drug dosages that we use. Okay, before I talk about the test dose. We do give the test dose before the first dose. Now, the test dose, what is the concept of the test dose? A small dose of the mix of the drug that we give epidurally is given as a test dose before a large loading dose. Because if it is intravascular, if it is intrathecal, then a large dose should not be given straight away. And that is the reason why we give a test dose and see that nothing is wrong, and then give the full dose. Now, let's see what is happening. What is the test dose normally given? Most of the situations, when you place an epidural catheter, we use the lignocaine 1.5 to 2%. The standard textbooks describe it as 1.5%, and which is not available with us. So we do use 2% lignocaine with adrenaline. 3 ml of that. This is the standard test dose. Everybody uses this. And which contains about 45 milligrams if it is 1.5%, and 60 milligrams if it is 2% lignocaine. And adrenaline, 5 mics per cc, that is 1 in 200,000. So 3 ml contains 15 mics. This is what is the test dose. Now, it can be extrapolated to bupivacaine, 0.5%, 3 cc with adrenaline, 15 milligrams, adrenaline, 15 mics. So this is also a test dose which is described in textbooks, but I think it's not a safe thing to give 3 ml of bupivacaine with adrenaline as a test dose in epidural, because in case it is intravascular, even 3 ml, that is 15 milligrams, is not very safe. That is why using a 0.5% bupivacaine as a test dose epidural, I would not advocate it. But I'm just telling you, it is there in the textbook, so probably keep it to compare. Now, supposing you are doing a hysterectomy under epidural analgesia, plain epidural, supposing you decide on that, what would you give? We give a loading dose of bupivacaine 0.5%, 15 ml, that is about 75 milligrams, right? So when you want to give a 75 milligrams as the loading dose, we give 15 milligrams as the test dose to find out nothing is wrong, right? This is what a large loading dose, a small test dose. Now let's see what we give in loading dose for labor analgesia with bupivacaine. There are two mixtures I told you, ULE and LDM. ULE, if we use 10 to 15 ml, it is about 6.25 to 9.3 milligrams. And LDM 15 ml is about 15 milligrams. That means that the loading dose itself is smaller than the test dose. So then why give the test dose? This is what the controversy is. So a small test dose before the loading dose, large loading dose does not actually work. This is what is controversy about test dose. Concerns about adrenaline, I don't know. In most of the institutions, they do not give adrenaline in pregnancy. Even for labor epidural, whatever it is, even for caesarean sections, if they want to load with the epidural, they don't want to give adrenaline. And our experience in Fernandez Hospital with more than 100,000 labor epidurals and more than 13,000 labor epidurals with me, and most of the caesarean sections, many caesarean sections done with plain epidural only, we have no problems using adrenaline. And we have done, especially in many of the centers these days, they have found out that adrenaline mixed local anesthetics do not have significant problems. But I don't know, it's again a controversial issue. Many people do not agree with it. But so that is one of the reasons why test dose is not very useful. The third problem is sensitivity of adrenaline in ruling out accidental IV cath. For example, why we give test dose is because you want to rule out an accidental intravenous or an accidental intrathecal placement of the catheter. Now, most patients, when you place an epidural catheter, are in active labor. And during contractions, you know what happens to the heart rate. Now, supposing you are giving a test dose and the patient develops a contraction, that the heart rate goes up to 140. Now, you are in doubt whether it is because of the adrenaline that you have given, maybe intrathecally, or whether it is because of the contractions. So again, that is sensitivity of adrenaline. Now, what is advocated is that you give the test dose if you want to give an adrenaline-containing test dose to rule out intravascular placement. Time it well, soon after a contraction, when the heart rate is settling down. Say it goes up to around 110, 120, 115, say, and it has reached the peak, the contraction is fading, and the heart rate has started falling. At that time, you give the test dose, probably this confusion will not arise. The fourth important thing is motor block. See, in most people who are very, very skeptical about motor block in epidurals. Even, I don't know, of course, you should not produce motor block is true. But at the same time, a short duration motor block for some reason also is not a very bad thing as well. But what happens? Patient cannot be ambulated, cannot be made to walk to the bathroom. The patient may be, to a certain extent, the perineal floor, the tone of the perineal floor muscles are weakened and the progress of the labor may be affected, and that's the reason why they don't want motor block. 2% lignocaine, 3 ml will produce some amount of motor block, and that is one of the reasons why they don't want to give motor block. So what is advocated is that use that large dose itself as a test dose. Use it in fractionated doses. Give 5 ml first, wait for a few minutes, and then give another 5 minutes. But the problem is that none of these test doses, the fractionated doses, rules out an accidental intravenous placement. So if you take out the Chestnut 4th edition, 3rd and 4th edition textbooks, they talks about this controversy about labor test dose, about 14-15 pages he writes on the controversy. And finally he says that in my institute, we use 1.5% lignocaine with adrenaline as test dose 3 ml. In my institution also, even today, we are using 2% lignocaine 3 ml with adrenaline as a test dose, and we are following it. And I don't think it has produced significant problems for us. So what is advocated is that treat every top-up as a test dose. So now you place the epidural, you're given a test dose, you're given the first dose of the epidural. The dose also I have mentioned, charged with the loading dose. Now what is the top-up? When to top up? You see, you started, the first peg is on, you're doing well, the second peg, and when to take the third one to maintain the good level of the block, when to take the third peg. So this is what is about the maintenance. Now, the top-ups in labor analgesia is always timed top-ups. We never wait for the labor pains to appear. Normally, it is said that most of these mixtures act for about 100 to 105 minutes. you give one dose of 10 ml or 15 ml of the ULE or LDR and get a very good analgesia. In about 100 to 105 minutes, the pain starts appearing. So this is preemptive analgesia. We give it at 90 minutes so that the pain has not appeared at all. And that is when we top up. So supposing if the first dose was at 11 a.m., the next dose falls at 12:30, naturally after 90 minutes. And what should be the dose? See, most of the times for our surgical anesthesia, for example, you are giving epidural for a maybe caesarean section or hysterectomy, you are given 2% lignocaine, say about 15 ml, and then about 45 minutes after the loading dose, you tend to give the top up. How much do you give? Usually 1/3 to 1/4 the original dose is given as the top up. Whereas labor epidurals, the volume, the dose given for every top up is same as the first dose. Now, this is a significant difference. Always time top ups every 90 minutes and always equal to the initial dose. That means that if you have given 15 ml as the first dose, give 15 ml again as the second dose, as the first top up. Now, always use as fractionated doses. Every top up should be used as a test dose. 5 ml, wait for 2-3 minutes. 5 ml, wait for 2-3 minutes. Wait for 10 minutes to get the good blockade. And if it is not enough, give the next 5 ml. Now, first dose was at 11. The second dose naturally was at 12:30. You are given the second dose also. Now, the third dose falls at 2 a.m., right? Instead, supposing if the patient gets pain at 1 o'clock itself, instead of waiting till 2 o'clock, you would have given the block at 2, the next top up. But at 1 p.m., the patient complains of pain. Now, this kind of pains, you call it as breakthrough pains. And you give half the original dose. That means if it was 10 ml, give 5 ml now at 1 p.m. And forget about this top up and give the next full dose at 2 p.m. So this is what is the protocol. If there is a breakthrough pain, give half the original dose and forget about that. Now, supposing if there are 2 or more such breakthrough pains, it's a red flag. That means that your catheter is probably not working well. So if it is more than 2 or more, and if there is some problem, and if the patient is not happy at all, don't have hesitation to pull out the catheter and resite it. Now, you have given the labor epidural, first dose, maintenance, everything went well, and now the patient is in second stage pains. The failure of second stage pains is one thing which gives a very, very low maternal satisfaction, because the pain at the second stage is extremely cruciating. And that is the reason why you need to manage the second stage pains very well. Now, the pain during second stage will be, last time also I have talked about it, that it goes to T10 to L1 high up and S2, 3, 4 low down. Most of the times you would have placed the epidural catheter either at L23 or L34. Now, during second stage, the drug has to ascend up as well as it has to descend down. And that is the reason why you need to give a large volume. That is the main thing. The second thing is, whatever you do, unless you take the patient to a good confidence, patient will never be happy. So for that reason, you must counsel the patient. Now, counseling means what? What to counsel, how to counsel, and when to counsel. Of course, you would have counseled the patients about the first stage pains, the second stage pains, what you do, all these things maybe you would have done in antenatal classes or before, the labor, before you place the epidural catheter, all that is true. But the best time to do the counseling is after you place the epidural catheter, gave the drug, and the patient is very comfortable. The first dose you have given, and the patient is smiling and thanking you. And that time you sit and talk to the patient. Tell her that the first stage labor pains are mild. It can be managed well, but the second stage pains are not easy to manage. Tell her that it is very severe, and tell her that we want you to bear down during contractions. So we would leave some amount of pain for you to appreciate the labor pains. You understand now when you get the contractions. Now, these things are done just to get her faith. In anticipation, you had told that second stage pains can't be managed very well. Probably she is in a better position to tolerate the second stage pains. You do give her good analgesia is a different issue. But in case you fail, this counseling would have worked. That is the most important thing. The second important thing is a large dose of the mixture up to 25 ml. I usually give for second stage labor pains. I don't give LDM at all. That is 0.1% bupropion I don't use. I use the 0.0625% only, and I use it at large volumes, say about up to 25 ml I give. This is for second stage pains. When the patient is full, you give the loading dose up to 25 ml, and then you wait for some time. Then you ask the patient to bear down. The next important issue is sitting position. There are many people who say that you make the patient sit up, the epidural drug descends down if the patient is sitting up. So this is very, very controversial issue. The gravity spread of local anesthetic is very prominent in spinal anesthesia, whether it is a hyperbaric solution, isobaric solution, or hypobaric solution. But in epidural, because epidural space is a potential space, the gravity spread is not very much evident. But one thing certain is that while injecting the drug, at the time you are injecting the drug, if the patient is in the sitting position, the drug descends more towards the sacrum compared to higher up. But after giving the drug, whatever position you give matters very little. So at the time of injection, so what we normally do is, in second stage pains, we make the patient sit up and then give our loading dose. So it preferentially spreads to the sacral segments to just a slightly higher extent. That is probably comes to our advantage. The textbooks say that a large dose of fentanyl, up to 75 to 100 mics epidurally, also helps in second stage. But I don't know. I'm very skeptical about it. The reason is fentanyl is a narcotic. It acts on the visceral pain. And in second stage labor pains, it is the somatic pain which is more evident and more difficult to manage compared to the visceral pain. Visceral pain can be managed with 25, 30 mics of fentanyl only. Whereas the somatic pains have to be managed by the sacral spread, for which a large amount of the local anesthetic becomes very, very important. Okay, so we have talked about the first test dose, the first dose of the labor epidural, the topping up, second stage labor pains. So this is the whole thing this is how we manage our labor epidurals. Now, troubleshooting. I think every one of you must have seen this picture. Jog Falls. It's a wonderful waterfalls. The deepest waterfall in Asia, just 100 kilometers from where I'm sitting now. It's just a 2-hour drive, and it's a beautiful thing, beautiful place. The problem with Jog Falls is that it also looks like this. Not only like this, it also looks like this. So one should know when to visit, where to stay, and how to reach the falls, or they have to be briefed for them to visit when the falls looks like this or like this. And this is what is troubleshooting all about. You are located the epidural, catheter negotiated, charged with the maximum dose, which I talked about. Okay. Having done this, within 15 minutes after the block, after the loading dose, you can get into 4 different clinical situations. The first situation is excellent analgesia. A correctly placed epidural, very good analgesia, very happy mother, the obstetrician is happy, the anesthetist is happy, everybody is happy. And thankfully, this happens in 95% of the situations. So this is situation 1. If this happens, no problem. The second one is an extensive block. More than what you want, more than what you expect has happened. Like excellent analgesia, but there is excessive motor block, there is hypotension, usually happens within 2 to 3 minutes of giving the dosage. And most of the times is probably is because the catheter is for some reason is intrathecal. If it is intrathecal, whatever dose that you have given is intrathecally administered. And that's why you're getting an extensive block. And how to manage the intrathecal catheter? I'm sure every one of you know an accidental intrathecal dosage of the epidural, how to manage. I will not go into the details. But one important aspect which I tell you, that any kind of hemodynamic disturbances in pregnancy, a manual left uterine displacement becomes very, very essential. And every one of us know it. But the question is, we tend to forget it at the time when there is hypotension. So the first thing that you should do if there is hypotension, whether it is intrathecal or placed or whatever the reason is, do a manual left uterine displacement. Don't forget it at all. The second one, even more tricky situation. There is no analgesia. Most of the times it is a lack of analgesia. Analgesia is not great. But there is signs of high spinal block. CSF you can't aspirate at all. And there is Horner syndrome. Usually patchy block. You might many a times with lack of analgesia, you have placed a lumbar epidural, you have given the dose, and the patient is unable to get a hand grip, and there is no analgesia. And this can occur most of the times. The diagnosis is very well written. It is subdural placement. It's even more a dangerous situation than the intrathecal one also, because it does not get recognized early. People tend to give more and more drug, and at one point in time, the arachnoid matter breaks and the dosage becomes intrathecal, suddenly producing total spinal. So if you suspect subdural, only thing that you need to do is remove the catheter and resite it. Now, so we have completed the two situations. The third situation. The third situation is a partially acting or a patchy block. Partially acting or a patchy block is not like this. Does not mean that it has acted here and there. No, it's not like that. It follows a particular format. It could be an asymmetric block, wherein the block on one side is higher than the other side. Now, this kind of an asymmetric block is always a possibility. The second one is, typically, some dermatomal segments are skipped. They are not blocked at all. The rest of the block is excellent. But one segment failure, one segment is missed also means that the patient is having some pain. It could be a unilateral block. One side blocked nicely, excellent, and the other side is left open. Or it could be a sacral sparing. This is also a great possibility. And the fifth one, the last type of the failure, is an inadequate pain relief. Here, the block is translucent. The pain penetrates and seen through the block. Thin. So the pain would have come down in intensity to a certain extent, but it is still not in the acceptable levels. Whatever the type of the format, whatever is the partially acting catheter, the reasons are these many. Now let's see the reasons one by one. The first and the foremost reason is the inadequate dose. Anytime, every year around March, April, and sometimes into the first week of May, there is a Kaveri issue between Karnataka and Tamil Nadu. It is not there every year. If there was sufficient rains the previous year and there was sufficient water in Kaveri, the problem is not there at all. The problem comes when the rains were less and there is less water in Kaveri, and who should share it? How to share it between Karnataka and Tamil Nadu is the issue. So that means that it was inadequate dose which has caused the problem. Uneven spread. See, I have gone to the anatomy department in the medical college myself, broken open the spine, opened the spinal cord, the membranes, the epidural space. I have dissected myself and tried to see what is there inside. The contents of the epidural space are so much that, in fact, I am not surprised if my epidural does not act. In fact, I was surprised how my epidural is acting. That much of contents are there in the epidural space, and how it is reaching every nerve and is acting, I was not sure. And that much of contents, the fat, the lymphatics, the nerve roots, the vessels. What is not there? Everything is there in the epidural space. The next important reason for a partial block is the air in it. I think I must have talked about it last time. If you use too much of air, air can form air pockets in the epidural space. And if the air pocket is around a nerve root, then the local anesthetic cannot come in contact with that particular nerve root and that nerve root escapes. And this is one of the reasons why patchy block can occur. So, to avoid this, don't ever inject too much of air, even if you are using loss of resistance to air into the epidural space. The nerve root could be in an unfavorable position. For example, if the nerve root is here and the tip of the catheter is somewhere here, lying down here, then, it's not easy for the drug to reach the nerve root and get the action. So probably, if it is like this, the nerve root is somewhere and the drug is getting delivered, the tip of the epidural catheter is somewhere else. And if the drug is getting delivered at this point, if the nerve root is here and the drug is getting delivered here, what you can do is you can pull the catheter a little, about 1 centimeter. And if you pull the catheter a little, maybe the tip of the catheter comes to a favorable position somewhere near the nerve root and it might probably act. The too much catheter in the epidural space, the catheter can get into the paravertebral space. Dr. Naresh Paliwal last week was discussing about this, and too much of the catheter into the epidural space, probably it might leave the epidural space through the paravertebral spaces and reach there. So it may not act. There could be some obstetric causes. The reason is, for example, if it's an occipito-posterior position, transverse position, or an android pelvis, scar dehiscence in thorax, or a full bladder, any one of them cause a high intensity pain, which you may not be in a position to manage with the conventional doses. There could be obstetric causes. So if the drug is not acting well, then you ask your obstetrician to examine once. There could be a full bladder, catheterize it, it will probably act. Or maybe the patient has become full. The pain may be in the second stage. You may have to give a second stage dosage. So there could be obstetric causes. The intensity of pain is so high that the dose requirement, both in concentration as well as volume, may be very high. Analgesic failure with a true epidural catheter placement also is probably in the range of 5 to 8%. So when the initial charging or the infusion does not result in an adequate block, what has happened? Two maneuvers to salvage the catheter are there. Number one is flooding with the additional dosage. You can give an additional dosage and you're always risking for the local anesthetic systemic toxicity. You need to be very careful about it. And the second one is partial withdrawal of the catheter and charging again. See, if you see here this time, see, this is the 15 centimeter mark and this is 14, 13, and the catheter is at 12.5 centimeters. 12.5 centimeters, I think, is a little too much inside. Probably. I don't know how much was the skin to epidural space depth, but most of the times it's about 4 to 5 centimeters. So this is about 8 centimeters inside the epidural space, and that is a little too much. So you can withdraw the catheter by about a centimeter and charge again. Repeat 50% of the initial dose supplement you have given when it is inadequate analgesia. Wait for 10 minutes. And if there is no satisfactory analgesia, pull the catheter by 1 centimeter and repeat the dose. If there is no satisfactory analgesia, remove and resite the catheter. This is what we follow most of the times. Have a low threshold to change the catheter. After all, the catheter is not my wife, you see. You can change it anytime. So this is about the third possibility. The last possibility is no analgesia. No analgesia means, where is the catheter now? The first and the foremost reason is the subcutaneous placement. Subcutaneous, I mean extra epidural, somewhere in the tissue spaces. And this is detected in the first 30 minutes itself. The main reason in pregnancy is due to the false loss of resistance. You see, in pregnancy, the tissues, because of the hormone actions, the tissues are all soft. Now, to get a loss of resistance to identify the epidural space, what we are using? We are using resistance to the injection of a fluid, either saline or air. And the moment that resistance is lost, that means from the past the ligamentum flavum and reach the epidural space, there is no resistance. Now, in pregnancy, the resistance itself is not there, or it is less. So the confusion about loss of resistance always exists in pregnancy. So you should be very, very good at eliciting the loss of resistance. Otherwise, false loss of resistance will lead on to the false catheter placement elsewhere, somewhere not actually there. And that may be one of the reasons why your epidural might fail. The second important reason is this. Now you see, if supposing there is an undetected intravascular placement, the catheter is in the vein. Now what will happen? You give 10 ml of the local anesthetic. All the 10 ml will become intravascular. Forget about the local anesthetic systemic toxicity, last for a minute. But what is happening? The entire drug is going into the systemic circulation. No drug is there in the epidural space for it to act. So, if the catheter is intravascular, the drug does not act at all. So, the epidural total failure, the most important reason is intravascular placement. No analgesia is the most striking feature in intravascular placement of the epidural catheter. So, if there is no analgesia at 15 minutes after full dose of the mixture, whatever mixture that you are giving, assume it to be intravascular and manage it as an intravascular catheter. Now, how to manage the intravascular catheter? I'll come to that now. So, supposing if the catheter not acting in 15 minutes after repeating the local anesthetic mix, the aspiration test is negative. You aspirate, there is no blood. The blood is not there means aspiration test is negative. And you are very sure of the catheter placement. Most of the times, all of us are practicing anesthesiologists. We know how the epidural catheter slides inside the epidural space. When you are pushing it, that feeling is fantastic. You appreciate it very much, right? And aspiration test is negative. It has not acted, but you're not very sure. You don't want to remove the catheter. You don't want to give a large dose. Now, what to do? For that, there is something called as numbing dose. And the terminology is coined by, again, my good friend, Dr. Sunil Pandya. And I have started using it and I have modified it a little. Numbing dose. Numbing dose is something, I told you, I discussed with you earlier itself, that in epidural labor analgesia, motor block is not a welcome situation. But this is one situation wherein we are going to produce inadvertently motor block and test my catheter to get a good motor block and then test it. This is what numbing dose is. Now, numbing dose, Dr. Sunil, I don't know why exactly, but he uses bupivacaine 0.1%, but I use lignocaine. Why I use lignocaine? I have my own reasons for it. What is the treatment for ventricular tachycardia? All of us are anesthetists. We know how to treat ventricular tachycardia. Of course, there are better drugs these days, but for time immemorial and even today, lignocaine intravenously, plain lignocaine, is lignocard, xylocard, is a very good drug for ventricular tachycardia. And what is the dosage? It's about 60 to 100 milligrams IV straight. So that means that giving 60 to 100 milligrams IV stat is not very dangerous. It does not cause any significant cardiac toxicity. It is in fact a treatment also. So lignocaine 1% 5 ml, which is 50 milligram bolus, is definitely safe even if it is intravascular. That is why to test an intravascular placement, I would probably use lignocaine 1% 5 ml as a bolus. And believe me, if your catheter is not intravenous and it is placed epidurally properly, 5 ml of 1% lignocaine should produce some amount of motor block after about 5 to 10 minutes. So, if you give numbing dose, it will rule out an intravascular placement surely. Now, this is flow chart. I think all of you should listen to it carefully, follow it properly. A full dose of the local anesthetic, LDM or ULE, whatever it is, 10 to 15 ml we have given. and after 15 minutes, there is partial analgesia. So on the left-hand side, I'm going to talk about partial analgesia, and on the right-hand side, a total failure, no analgesia. Supposing there is partial analgesia after 15 minutes, you pull the catheter by 1 centimeter and charge with 50% of the original dose. Now, after 15 minutes, if there is no improvement, now you give a numbing dose, that is 1% lignocaine, 5 ml, and within 15 minutes, there is no motor block, you assume it to be intravascular. If there is motor block, it was epidural. But if there is no motor block at all, assume it to be intravascular, remove the catheter and resite. This is what we follow for partial analgesia. Supposing if there is no analgesia in 15 minutes, there is a great possibility of intravascular now. Now, this one step of pulling the catheter by 1 centimeter and charging it is skipped, and we give a numbing dose straight away. Numbing dose after 15 minutes, there is no motor block after 15 minutes. Now, I assume it to be intravascular, remove the catheter and resite. Now, this is, I think I'm clear about whatever I'm talking about. So let us continue. So this is the flow chart for partial analgesia and no analgesia whenever we face it, and this is what we follow. Now, the next issue that I'm going to talk about is the continuous infusion. Continuous infusion, if you want to use, we use either ULE or LDM, the same concentration. You can use any of the leobupivacaine or ropivacaine mixtures also. The 12 ml per hour is the basal infusion which we follow, 12 to 14 ml, and 4 ml boluses for every breakthrough pains. Now, very early stages, instead of using 0.0625%, 0.05% itself would be sufficient as a continuous infusion. This is what the textbooks say. But we have stopped using infusions. We used it somewhere in 2005, 6, 7, and then I stopped using continuous infusions, and we only use intermittent boluses. The reason is this. See, when you give local anesthetic mix epidurally as an infusion is a very slow injection. When you are injecting it very slowly, all epidural catheters has 3 holes. You all know. The drug escapes from the proximal hole only and stays there. Because it is not, getting injected fast, very slowly it's getting injected, the drug stays there. And that water gets absorbed and the drug gets concentrated at that point. The drug does not get distributed to the other spaces, whereas it stays there requiring a larger infusion. The dosage requirement becomes more and breakthrough pains become more, and you tend to give boluses in between. And these boluses act rather than the basal infusion itself. Whereas when you give intermittent boluses, every time you charge the catheter with a force, the drug gets distributed well and the action would be better off. And this is the reason why we use intermittent boluses rather than the continuous infusions. Now, the next issue is about incidence of caesarean death. Now, if you see any of the literature, this is an RCT in the epidural versus patient-controlled meperidine analgesia during labor. It's a 1997 article, an old one. There was no difference in the rate of caesarean deliveries between the 2 analgesia groups using intention to treat analysis. There was no difference at all. So if you take Cochrane database, which is slightly more recent one, 2005 article, and many articles after that, there is no significant increase in the caesarean section rate overall between the epidural group and the non-epidural groups. So Cochrane database in 2018 also, an epidural versus non-epidural, caesarean delivery for fetal distress, 3,062 cases epidural, 3,181 non-epidural groups. There was no significant difference between the 2 groups as far as caesarean delivery incidence is concerned. So if you ask me the question, does epidural increase the caesarean deliveries? The answer is a strict no. Whereas the incidence of instrumental deliveries, most of the articles, this Cochrane database in 2005 also clearly says that there was an increase in the length of the first and second stage of labor, Because there was an increase in the length of the second stage labor, the obstetricians tend to shorten the second stage labor, maybe with instrumentation, either forceps or a ventouse delivery. So the instrumentation incidence increases. Yes, but with least untoward consequences. Now, our own experience, first 13 years, just concentrate on this. From September 2004 to August 2017, I had compiled. Unfortunately, hospital wherein I was working closed down for some various management issues, and the whole database was completely lost. So I don't have any data as of today, but I had presented it in the Jodhpur conference. At that time, I had the privilege of having the statistics. Now I don't have it, but this is an unpublished data I'm going to tell you. The total deliveries in that period in our group was 9,600 plus. Number of cesarean section was 2,725, which amounted to around 28.29%. This was the total cesarean sections, of which elective cesarean sections were 1170. 41% of the cesarean sections were elective cesareans. Maybe because of the primary breach, maybe because of the previous sections, maybe because of the fetal problems like prematurity, IUGR, and such things. Many elective cesarean sections were there, and that accounted for about 41%. Now, so barring the elective cesareans of 1117, 8,514 patients were given a trial of labor. Now, this large group, epidural group, was an whooping 6,866. That is 80% of the patients in whom a trial of labor was given in our hospital received epidurals. This is one of the highest take rates. Even Dr. Sunil Pandya at the Fernandez Hospital does not have these figures. This is a very high figure. Excellent. And our obstetricians promote it to a very great extent. Non-epidurals were 1648 only. You see the cesarean section rates. In the epidural group, the cesarean section was only 18%. And in the non-epidural groups, it was 22%. I don't say that the epidural reduced the incidence of cesarean section because of these small numbers, but I can definitely say that at least it did not increase. Instrumental delivery rates with non-epidurals stood at around 35%. Whereas with the epidurals, it went up to about 42%. There was a marginal increase in the instrumental delivery rates. The last issue I'm going to talk about is the solo practice. Time required for any delivery is very much unpredictable. All of you know. Complications can occur anytime. So if you are a solo roaming anesthesiologist, going from one place to other, never practice labor analgesia at all. Answer is group practice. And I know you being in the Ozone group, one of the larger groups compared to me, group practice is probably the real answer for labor analgesia. The question is how to organize a group. Who should be your partners? Anesthesiologists only? Anesthesiologists and obstetricians? Anesthesiologists, obstetricians and pediatricians, etc. All combinations have been tried. But one bottom line is that you need to have like-minded people. Not only like-minded people. The entire group should have a profit-sharing group. Every individual in the group should have monetary benefit. Then only it works. A good company and a long journey makes it seem shorter. I focused the slide in one of the CMEs at Hassan in Karnataka, where one of my MBBS classmates is an ophthalmologist. He was sitting actually when I was talking. He came and sat at the back as an ophthalmologist. Then when I focused this, he asked me, who is the anesthesiologist in this picture and who is the obstetrician? Then I told him that anyone who gives his shoulder for somebody else to lean on and cry is always an anesthesiologist. Now, how to make the group work? Send your group partners as observers. The best place is Fernandez Hospital. Your obstetrician or the anesthesiologist appreciates the calm labor theater and happy participating mother in that place, and train your partners in specific small jobs. Airway management, test dose, top up, monitoring, asepsis, examination of the parturient, cervical dilatation, oxytocin infusion, all these things can be trained to your partner. You work as their resident and make them work as your resident. I think I talked about this during my last talk as well. And most of the times, we tend to rely on our ELT nurses, train them as pain nurses. And you can rely on, see, I have my nurses who are working with me from 2002 onwards. About 25 years they are working with me. Probably that will help in our group practice. Expand the group as and when necessary. This is how our group started. One anesthetist and the two obstetricians. We added a pediatrician, we added another anesthesiologist, one more pediatrician joined, and the group expanded. And you see that lady who is an anesthesiologist. She was my resident actually. And this is that epidural baby. I had given epidural for her delivery. And this is a good, excellent group. But for a few people, you all can recognize Dr. Sunil and his wife, Dr. Nilesh Nafde, Dr. Ravindra Bhatt, and maybe, but for these, a few people, all others are my partners. Thank you so much.